My name is Emil Bethel. I'm on the staff here and at the University of Maryland Neurosurgery, chairman of the Department of Neurosurgery here at University of Maryland, Baltimore, Washington Medical Center. Dr. Liang and I are going to talk a little bit tonight about the title of this is, living life without pain. Well, we all know that's not possible. And it's God's plan is to give us a little pain to get through life so that we know we're still alive. So the question is whether or not we can get to a stage in our lives where we have just enough pain to keep us alive, but no pain to stop any of the things we want to do in life. As I turned 50, I realized after all the orthopedic injuries that I suffered during school, high school and college playing lacrosse that I woke up one morning with pain shooting down my leg and rolling over in bed. I realized that this happens to everyone. I knew this already, but I thought I would never have this problem. But we all get it, okay? It's part of the aging process, just like these new glasses that I have and the gray hairs that my kids are giving me. So I basically want to go over some of the things that Dr. Liang and Dr. Solomon and I take care of and how we take care of them and how we can get you through to a better life as life progresses. I'm going to speak a little bit about the cervical spine, which is the neck, because it represents half of most of the spine disease that we see. It only represents 1/3 of your entire spine. The thoracic spine, which is from your neck, below the bottom of your neck down to your lumbar spine, the thoracic spine only represents about 1 or 2% of all the disc disease that we take care of. So most of your problems when you have problems with your spine are in your neck or in your lower back, below your rib cage. So those are the two areas we're going to focus on tonight because that's 99% of what we do. I'm also going to talk about the operative measures that we take on to help you with through these painful moments in life and through these painful periods in life. So basically we get nothing out of this lecture, especially as something like this beautiful ham dog. We really are, we're part of the faculty, so this is part of our job, but it's also part of our pleasure. We love to educate the community about the things that we do. We all have diseases, right? We all come down with something. When you're a kid, you have the cold. When you're older, you start to get things that affect you because of age and wear and tear. But the spine disorders that we focus on, although most of them tend to be due to wear and tear or degenerative processes, we also see things that are traumatic and the combination of the traumatic and degenerative things as well. We see infections can affect your spine. As well as cancers can affect your spine. We call those neoplastic disorders. And then sometimes we're born with a problem in our spine because of development that can progress to a more degenerative process or can cause trauma or some other process that we need to correct as well. So when we break problems down in the spine, we break them down into these 5 categories. The most common one, of course, that we all suffer from is the degenerative one. And usually that's due to repeated trauma. It's always our goal to try to figure out which is the most important thing. So when you're looking at this beach picture, the first thing you pick up is this pretty little otter and this great alligator. So you figure the most dangerous thing to you is going to be this alligator. But actually, if you were to pick one of those 2 animals to deal with, you'd probably pick the crocodile because the otter's just as mean and just doesn't look as nasty. So when we're trying to figure out things in the spine, we have to think about the nerves. We have to think about the soft tissue. We have to think about the skeletal system. We have to think about the ligaments, the surrounding structures, and how we're going to correct those things in order to make your pain better. So you have to understand the anatomy of what's going on in order to figure out where the signals are going to the nerves to cause your pain, which is a central response to something going wrong in the area of your body where there's damage or inflammation or destruction. So which one of the structures that are in this part of your spine are causing the pain? Let's go back and look at what your spine is made of. So looking at the neck, you have your skull and you have 7 cervical vertebrae. Okay, so starting at C1 going all the way down to C7. The 2 at the top, the C1 and C2 are special. They are called the atlas and the axis, C1 and C2. And the reason they're special is because their anatomy is different in that one has a little peg that fits inside of a ring, which is C1. And that's where you do most of your neck rotation. So when C1 and C2 are in motion, they're the ones that are doing most of your rotational movement. The subaxial spine, which is the next The next 5 vertebrae are a little more what you would think of as a normal structure. They have a body, and they're stacked on top of each other like dominoes, and they have a ring, and the spinal cord goes down through that ring. All of these are connected by ligaments, and those ligaments stretch from the front of the bodies all the way to the back of the bodies, and then you have ligaments in between, in the back of the canal, between the little ribs that you feel on the back of your spine, which are called the spinous processes. And all these ligamentous structures are important to hold your neck stable. Now remember, we're an erector creature. In other words, we stand up, right? We're the only hominid that stands on 2 legs all the time, most of the time. And because of that, all of our musculature is in the back that holds us up. So when I say we're an erector creature, that means that we're in extension most of the day. All right, so all of the muscular strength is in the back of our neck. There's nothing really holding your neck forward, okay? You let gravity pull your neck forward. There's some expression muscles and some muscles that turn the head that help structurally, but pretty much your whole neck is being held up by the back, okay? So all of these ligaments are there to help all those bones not move too far. Okay, they're like rubber bands in between the bones so they don't stretch out of place or they don't move too much whenever they're put against extreme forces. So when they're damaged, of course, they have little nerve root endings and they can cause pain, just like the bones. The bones have little nerves inside them that dig into them that when they're broken, just like a broken leg or a broken arm, can cause pain. So running down the middle of the canal in your entire spinal column is the spinal cord. It goes all the way down to the top of your lumbar vertebrae before it turns into nerves. And Dr. Liang will explain that. But basically in your neck you have 8 pairs of spinal nerves, and those nerves are numbered based on where they go out of the hole. So the first one starts above C1, the last one ends below C7, which is the C8 nerve root. And each one of those nerves, like a telephone system, goes to a different part of your arms. Okay? So the nerves that come out through your neck are the ones that supply all the muscle groups in your upper extremities. Your spinal cord is like a big telephone system. It starts in the brain, which is the telephone company. The spinal cord comes down and it lets off telephone wires to all of the houses. In other words, the other muscle groups. And those nerves have both a motor function, which means they supply a muscle to move, and they have a sensory function, which is supplies the sensation for all the different modalities. In other words, pain, temperature, pinprick, all of those for a certain area on your body. Okay? And in this case, it's for the areas of your arms. So each one of these nerves is responsible for a particular part of your upper extremities. So the other important structure that comes through your cervical cord is this little blood vessel right here, and that's called the vertebral artery, and there's one on each side. And that's important because it's one of the 4 major vessels that goes to your brain stem and brain. Okay, so it actually comes off of the major vessels in your chest, goes through a little hole on the sides of your vertebrae, comes into the skull, and then supplies your brain stem and the back part of the circulation for the big circle of blood vessels at the base of your brain that spreads out all over the brain. The one interesting thing about the cervical spine versus the rest of your spine is that all of the joints are flat or close to flat. So with being in that plane, they actually have the largest range of motion in your spine. So you can move in every direction with your neck, okay? And that's so we can survey our entire surroundings with our eyes. In between all of the vertebrae, there's a collapsible disc, okay? Now this disc is made up of 2 parts. And basically what it is like a pillow. And these little pillows are in between all of your vertebrae, except for the one between C1 and C2, which is the special area where you do most of your pivot, your rotating. There's no disc there. These discs act as cushions and joints so that you can have motion in your neck and in your back. All of the structure, the 2 structures of the disc are affected by everything that goes on in your world. So when your head is in a bad position, it's stressing. It's sort of like walking on the side of your sneaker. All right. When it's in a bad position, it takes pressure abnormally. When it's stretching out, it opens up. And with time, that can cause damage to the disc. It can tear, okay? When the forces are hard to a direction, that can cause problems with the disc. If you're loading things on your head, that can cause it. What you eat What you do with your body can affect how these discs are maintained. So we know for sure that smoking affects the disc because the disc is one of those structures in your body that doesn't get a great blood supply. So when you starve your body of oxygen, when you're smoking, you actually are affecting all the tissues in your body, and the discs get affected pretty early. So they can weaken it prematurely. And then, of course, with age, we all wear out. Okay, so the disc can become more and more damaged. The body has a way of healing itself. So when the disc becomes degenerated, the body wants to keep that stability and structure. So the first thing it does is it tries to build some structure around that bad disc in order to help it, to help it not become unstable and not move too much. So what it does is it builds bone. And that's where you'll hear this story about bone spurs. So bone spurs are basic, and they can happen in any joint in your body. They're basically an area where the bone is overgrowing in order to help support the area where you have the weakness. And you'll see it in your knuckles, all right, when the joints start to go bad. You see it in your neck when the disc starts to go bad. And you start to grow these bones around the area where the disc is damaged. And they spread out, kind of not knowing where they're going. And sometimes they can impinge on the structures around them, and we'll talk about that as well. So this is part of the aging process as well. It's an age-related problem. It happens in the areas where you move the most, right? So we don't see as many bone spurs in the thoracic spine because your rib cage and everything keeps you pretty structurally sound there. But when you get down in the lumbar spine where you're doing a lot of this and a lot of loading, and in your neck where you're doing a lot of rotating and a lot of static positioning, you see more bone spurs. What happens is the disc, as it degenerates, it dries up and it shrinks. And when that happens, you start to get the bones getting closer and closer together, and that forms a reaction that's actually causing more bone growth. All right, they rub together, and they can actually cause them to want to seal together because it recognizes that something's wrong here. I got to heal this. And it's just like a broken bone anywhere else. It tries to bridge the gap between the two bones that are now too close together to form a mobile structure. So it's trying to fuse you. So when the load on this column is not necessarily balanced, maybe you sit like this all the time, you're going to form more bone spurs in that area. Okay? So I've actually had patients who have had difficulty swallowing because the bone spurs because they've been in this position so long, the bone spurs are so big that they push on the back of their esophagus and block their ability to get food past the bone spurs. And what happens with that bony growth is the bones grow, the ligaments that I showed you that surround the bones start to kick out, and as they're getting rubbed against, they become inflamed, and they actually thicken as well. So we get what we call ligamentous hypertrophy, which means the ligaments are bulging and buckling. And you can imagine like a rubber band in between two bones, if the disc's collapsing, then the ligament buckles as well. Because those bones are coming close together, that ligament doesn't lose any of its length, so it has to do something, so it folds and buckles. Then it becomes inflamed behind it, and that becomes more pressure on the areas that we don't want where we don't want pressure, like in your spinal canal or against a nerve, okay? And that can cause another process that we'll talk about that we call cervical stenosis. So when all this degeneration happens, as you can see, so we'll look at the red discs in between, what happens is those discs collapse and they start to buckle against the spinal cord. This is the spinal cord inside the spinal canal. This is a bologna slice looking through it from side to side. So that's the top and this is the bottom. The white that you see is the spinal fluid. Okay? And that spinal cord, which is sitting in the middle, right here between your 5th and 6th cervical vertebrae and between your 6th and 7th vertebrae, because of the collapse and the buckling and the bone spur formation, is now compromised. The space is compromised. So you don't see that white around those areas near that disc because the cord, there's no room. The cord is being collapsed upon, and that can cause symptoms that are related to your spinal cord and your nerves in that area not functioning well. This is another picture of the disc. You have this outer ring of fibrous tissue called the annulus fibrosus. It's like thick cartilage. And then in the middle, we have what I always describe as crab meat, which is called the nucleus pulposus. So it's like a jelly donut. And what can happen is you can tear fissures in that annulus, and the crab meat pops out. And that's when you hear herniated discs, sequestrum, These are terms that we use to say that the disc is not in its normal place and some of the tissue is moving out into space it's not supposed to be in. Sometimes it doesn't even take a tearing of the annulus and pushing out of the material from the inside. It's actually the material inside from collapse pushing on the wall, and the wall itself bulges out. And sometimes you'll hear the term bulging disc, all right? And that's when the disc collapses and the whole thing bulges like a bleb on your car tire. So these little tears can cause these leaks, as I said before, or the actual pressure on that area can actually cause bulging of the whole thing. I'm going to go through that, because this is all Danny stuff. So I'm going to ask Dr. Liang to come up and do his part, and then we're going to talk about some of the surgical options that we have at the end.
Hello, everybody. Thanks for letting me speak to you about back pain today. Let's see. All right. So I work with Dr. Bethel, and we're both part of the University of Maryland and part of this hospital. We're neurosurgeons. We take care of all the different spinal conditions. And I'm here to talk to you about back pain. And a lot of the stuff I'm going to talk to you today is going to be very similar, kind of what you've heard about the neck. It's the same thing as going on with the back. And the reason why I'm kind of repeating it, because these are the points we're trying to really drive home. So they say repetition is the, is the best. So again, back pain is very common, and it's just like neck pain. It's your back is a mechanical structure. And the thing, if you can take home anything, is that people develop back pain because it's a disturbance or an alteration in the mechanics of your spinal movement and spinal stability. And that's what causes back pain. And there's a lot of things that are responsible for that, but that's what causes back and neck pain. Leg pain, on the other hand, leg pain, leg numbness, tingling, if it's a spinal issue, it's caused by pressure on the nerve. So even though they're related, but they're actually two separate disease processes. So that's what I really want to drive home, is that back pain is an alteration in the mechanics of your spine. Okay. So just real quick, the epidemiology. For the they estimate that the lifetime prevalence of someone having back pain is over 80% in the United States. That's obviously, it's an estimate. It's probably closer to 100. I mean, I've had back pain before. Everyone's had some sort of severe back pain at some point in their lives. And the 1 year prevalence is about 15 to 20%. This is data that was collected by epidemiologists, people who study data on disease processes. So basically, the take-home message is that it's going to affect all of us at some point in our lives. It's the second leading cause of disability in the U.S. So it's a big problem. I think the first cause is stroke, I think. But it's so it's a big issue, not only in the United States, obviously, but in most of the developed world. It's estimated that about 149 million workdays are lost per year due to back pain. That involves time off from work to rest, treatment, getting treatment for it, recovering from surgery, et cetera, et cetera. And that number is hard for us to comprehend. So a better number is estimated that $100 to $200 billion per year. That's per year of cost. So that's not just the treatment, not just the medications and paying for physical therapy and the surgical and rehab, but it also includes lost productivity. So time you're off from work, or being disabled and losing the productive years of your life due to back pain. So that's a staggering number. Just to reiterate the anatomy, so in general, Dr. Bethel spoke about the cervical spine, but just to tie everything together, our spine is a certain shape, and it's developed that way since we were neonates. And as we started to learn to crawl and then eventually walk, our spine develops these curves, these special curves, for a biomechanical purpose. What it does is it aligns the weight of our head, and it aligns our center of gravity over the entire length of the spine, so that we're at a mechanical advantage when we stand up, that everything is very well balanced. So, and And this, again, remember what I said, this disturbance of this balance causes the back pain. Also, the other thing to keep in mind is that we have lots of muscles in our neck and our back and our thoracic spine and low back. So you can just, you don't need to, all this, a lot of very messy slide, but the whole point of it is you can see that there are enormous amounts of muscles, ligaments, muscles connecting your rib cage to your spine, your one spine bone to the other spine bone, your rib cage to your hips, your back to your hips, to your gluteal muscles, everything, your shoulder blades, your shoulder, your neck, your head, and there's a lot of nerves. So it's the biggest muscle organ system we have, and that there's a lot of area for that to go wrong and to cause pain. And that's why back pain and neck pain can sometimes be very difficult to pinpoint, as Dr. Bethel was just trying to say, that we're trying to figure out where the pain is coming from, what are the pain generators. Focusing on the actual, just the spinal bones itself, it's also very complex. This is the lower spine. The bones are bigger than the neck, but basically the same structures exist. You have the gigantic, the bony structures with the disc in between the vertebral bodies, and that forms the biggest joint. There's also joints in the back, the facet joints. There's the spinal cord and the spinal cord coverings, the nerves coming off from each level, bones in the back, and again, remember there's muscles and ligaments covering this. So it's a very complex mechanical structure. So what's the function of the back? So number one, it provides structural support, right? The bone, it's a scaffold for our body to maintain, our shape. It absorbs shock. Again, the discs in between each of the bones absorbs the daily twisting and bending, and it keeps the bones from getting too much of the stress. Also, the joints in the back, they move a little bit to accommodate for the shock as well. It provides mobility, so the muscles and the joints together allow us to bend and twist in a certain amount, but obviously not too much, but just the right amount. And finally, it carries electrical signals. So basically the nerves, the spine, it protects it, but the nerves are carrying those electrical signals to your fingertips or your hand or your knee or what have you. So what are risk factors for developing back pain? Well, the first thing is something we can't control is age. This has been very well studied that as we all age, that the prevalence of back pain, the incidence, everything goes higher. It makes sense. When we're all in our teens and 20s, probably never thought about back pain, and as we get older, we all comes into play at some point in our lives. Another well-studied and published risk factors are occupation. More of us are working longer, more years and working longer hours. But you would think that just physically demanding occupation will put you, a risk factor for back pain, meaning like plumbers or construction people who are working, carrying heavy loads and working in crazy positions all day long. But just the opposite is true too. People who are very sedentary jobs where you're going into the office, sitting from 8 a.m. to 5:30 p.m., working on a computer that's maybe too low and the chair is not that comfortable, and it's going to give you neck strain and back pain. This is kind of a little cartoon of, at some point we were working, if you believe in evolution, we were walking upright, and then a lot of people end up working in this kind of funny position on a desk, sedentary, and that's not what our bodies evolutionarily was meant to be doing, So something went terribly wrong. Another risk factor is stress. It's been proven that when you're under a lot of stress, your incidence of getting back pain is higher. There's a lot of chemical changes in your body that occurs with stress. There's a emotional change that changes your perception of pain, et cetera. And obviously when you're under stress, you may not be doing the same activities you're doing, and your function is altered, and that may kind of change your routine and change the stresses on your body. Obesity is a big issue with back pain. That's a very big deal, and it's really a major cause of back pain. What happens is, remember, our spine is a structural support system, and again, remember, our center of gravity is basically should be aligned with our spine. As we all age and we gain weight, most of us gain weight in the front. So as you gain weight in the front, in our bellies, et cetera, it shifts our center of gravity forward. So it's kind of like if you were carrying a backpack. We all carry backpacks very close to our bodies, but if you carry a backpack around with heavy books, like out here, it's going to start stressing out your spine. So that's because you're shifting your center of gravity in front of your spine. And as Dr. Bethel spoke about, all our back muscles are extensor muscles, and so those muscles are always trying to pull us back when there's a big force in front of us. So obesity really puts stress, not only weight on the bones and the joints, but it's shifting our center of gravity forward. And finally, the other big risk factor is depression. That's kind of related to stress. There's a lot of people who are depressed have a higher incidence of getting back pain, chronic back pain. They're not as active. Usually depressed people are not as active as they were, and there's also, again, a psycho-emotional component to sensing pain and processing pain. So what are some of the causes of back pain? Someone, I don't know who, but said back pain is youth leaving the body, which is true. And again, this slide is just to highlight all the muscles we have in our back. So one of the most common causes of back pain is muscle strain. So just like if you were to go, when Snowmageddon hit in, February, and we all had to shovel ourselves out for days, probably back pain, everyone had back pain because of the heavy shoveling. That's because you strain your muscles and all the ligaments, and it takes time for that inflammation to come down. So it's probably the most common cause of back pain. It's simple muscle strain or a muscle pull. This is common in as we age as well, and more common in people who have osteoporosis. The thoracic compression fractures, these are something we see all the time. And this is when the density of the minerals in your bone decrease. Instead of being a nice, strong bone, it sort of becomes like styrofoam. And even minor sort of pressure on the spine, in the thoracic spine and lumbar spine, you can get a sort of a crushing down of that styrofoam kind of bone. And again, because of that bone is crushed down, it's not able to provide the structural support it used to. So that's what causes the pain. Remember, the back pain, I keep saying, is an alteration in the mechanics or the structural stability of your spine. And as that occurs, then the muscles in the back have to try to compensate, and they start to get inflamed and stressed out and start causing pain as well. So this is very common. It's also very common in postmenopausal women who are fair-skinned, people who are very susceptible to getting osteoporosis. Obviously, spinal trauma, this looks painful just looking at it, but you can see that the bones just from a car accident were totally sheared off in alignment. That's something we can't prevent. Like in the neck, degenerative disc disease is one of the most common causes. Okay, again, remember they're shock absorbers, and they form a joint. They allow for a certain amount of movement, not too much movement. But as the disc, as you can see here, degenerates, you see these are more normal discs up here. They're kind of black on the outside with the white, that crab meat, cushiony stuff on the inside. But when it's all black, it means all that cushiony stuff inside is all dried out, so it's not really a pillow anymore. And that causes stress on the bones, and then also stress on the joints in the back, trying to compensate for it, which then triggers the muscles to work harder. And this all triggers back pain. So that's when the disc is unable to withstand the normal daily loading forces, and the joint function is decreased. Like in the neck, you can get herniated discs in the low back. This is when, again, the disc, the soft part of the disc pops out. The The back pain comes from the intense inflammatory reaction from that splitting of that capsule, that annulus fibrosis that Dr. Bethel was talking about. When that thick ligament splits, just like any other ligament, like your ACL or anything like that, it creates an intense inflammatory reaction. So people describe the back pain. But the disc itself doesn't cause back pain. It actually causes leg pain or leg numbness or tingling or weakness because it pops out of the disc and then it gets trapped in the spinal canal and usually it can push against a nerve. And that's why it causes something like sciatica or a very specific area where you feel a shooting pain down your legs. Lumbar stenosis, that's just the same thing as in the cervical spine. As you develop bone spurs and ligament hypertrophy from just chronic degenerative changes from overuse of your spine, it causes narrowing of the spinal canal. See up here, the spinal canal is a normal width, but then as the bone spurs build up to combat the stress, it happens to then start pushing on the nerves. So this typically doesn't usually cause back pain. It can just, because the joints may be degenerated, it can trigger muscle stress, but this usually causes leg pain, nerve problems, numbness in your legs, things like that, because of the pressure on the nerves inside the canal. Okay. Spondylolisthesis. So this is when when we talk about the disc degenerating, again, it provides a structural support, but as the discs degenerate, then it may not provide that structural support, and you see where one bone starts to slip in relation to the other. So they're starting to become misaligned because that joint just cannot hold everything in place anymore. This can be caused by degenerative changes, or it can even be caused by a small little fracture called the spondylolysis, where there's a little fracture in the bone, and it doesn't have to occur with trauma, but this fracture in the bone occurs where then essentially the front of the bone is disconnected from the back of the bone so that the facet joints don't really do anything anymore, and that segment is just really relying on that degenerative disc, and then over time, as that degenerative disc gets weaker and weaker, then one bone starts to slip in relation to the other. And as that slip occurs, then again, keep repeating it, the muscles and the ligaments in the back have to try to compensate for it, and you're trying to hold it back, and that's, over time, what causes chronic back pain. Obviously, scoliosis is a common problem for back pain. It's any abnormal curvature of the spine. Again, that's when our normal curves are shifted so that our biomechanics are off and the center of gravity is off, and that translates to muscle and ligament stress, trying to compensate for the abnormal curves in your spine. So those are all kind of more the normal stuff that we see in our offices on a day-to-day basis, and usually due to degenerative conditions and things like that. But I'll just go over some of the more dangerous conditions as well, just spinal infections, back pain. Risk factors are recent infection, if you have a big urinary tract infection or kidney infection or some sort of skin breakdown or joint infection. That infection can travel through your bloodstream and can lodge into your spine because the bones are very vascular. It has a lot of blood vessels, so obviously if there's a lot of highways going to your spine, then those little bacteria could travel there very easily. Immunocompromised patients, their body just can't fight off normal things, so they're more susceptible. And if you've had any major invasive procedure, but this is basically where bacteria infects the disc or the bones, and again, they destroy the structure of the bones, and you start to get some instability and alterations in the mechanics. And you can see here the bones are relatively aligned, but here you can see that in this patient that the bones are starting to slip because of such destruction of the normal anatomy. Tumors can cause back pain. Most common cause are metastatic tumors. Those are where tumors start somewhere else but then spread to the spine through the blood vessels. Patients with lung cancer, breast cancer, prostate cancer, kidney cancer, things like that, skin cancer, can all develop metastatic spinal tumors. And just like with infections, they destroy the architecture of the spine and cause instability and can cause back pain. They're benign tumors. You don't have to really remember these, but these are just benign tumors from the covering of the spinal canal or the covering of the nerves that can also slowly erode the bony structure and cause instability. And there's bone tumors and spinal cord tumors that can also, you can see a little tumor right there that can cause bone pain because they're eating away the bone and causing an intense inflammatory reaction. This is an important slide because there are a lot of back pain is so complex because there's so many structures and so many related structures like your hips and your pelvis and everything, so that there's a lot of what we call back pain mimickers, so things that you feel back pain but it's not really due from your spine or your spinal bones or the nerves. So patients with sort of hip issues like greater trochanteric bursitis or pelvic issues like sacroiliitis can also have chronic back pain, but they're not really from the spine itself. Piriformis is a major muscle in your pelvis that involves leg movement that can be inflamed and can cause pain, but it can also hit the sciatic nerve and cause sciatica, but that's not really from the spinal structure. A kidney infection can cause back pain, can cause sort of in the side flank pain. The kidney is right against your spine and in the back, and any kind of inflammation can cause back pain. An aortic aneurysm, it's the big artery that carries blood to your legs from your heart. As it dilates, or if there's a problem, it can cause back pain. And gynecological disorders, women with pelvic inflammatory disease or ectopic pregnancy or ovarian cysts, they can also inflame, touch the inside where then you feel back pain as well. So it's important for a physician to be able to evaluate your back pain and determine whether it's really from the back or is it from something else. Because obviously the treatments are very different. Okay. So diagnosing it. So this kind of section is more important for all of us. I'm going to talk about just the non-surgical treatments. So number one is what's important is your history of symptoms. How long you've had the back pain, whether there's leg pain or numbness or weakness involved, or if the back pain is worse with certain positions. It can all give us a clue as to what's the cause and of your back pain, or if it's not even related to your back. Physical exam is important. That's why we have to see you and examine to see if you have any weakness or if any certain maneuvers triggers the back pain, to differentiate it between the mimickers and real true back pain. And then imaging. So obviously we can't really see inside of you. We don't have X-ray vision, so it's typically imaging done with so we can see what's going on inside. And again, the most important thing is we have to use all three to attempt to diagnose and formulate a treatment plan. For us as surgeons, it's very difficult to figure out what's going on if we don't have all three of these and put all this information together to come up with a reason why someone's having back pain or leg pain. Imaging can be in the form of simple X-rays. They don't tell us that much information, but X-rays are really just only good for telling us perhaps the bony structure and the alignment. Sometimes we do dynamic studies, meaning bending and flexing X-rays to see if there's any movement. That can be helpful in that regard. CT scan is it's more radiation, but it gives a more in-depth detail of the bones, so it can look at fractures and things like that better than with more sensitivity than X-rays. But the best thing is usually an MRI. The MRI really gives us a really in-depth look at the soft tissues, seeing what the discs look like, the ligaments, the nerves. So that's what we really rely on most of the time. If you can't get an MRI, a CT myelogram is another study. That's where they have to do a radiologists have to do a lumbar puncture, and they inject dye into your spinal canal, and then they do a CT scan. So the MRI, some people can't get them because either severe claustrophobia or they have pacemakers or some other metal in their body that's not compatible with MRI, so it's not safe. So the next best thing is a CT myelogram, which the dye can hopefully highlight the spinal canal. When we do a CT scan, then we can infer certain information from it. EMG, that's a electromyography, a nerve conduction study. It's like it's like what an electrician does to diagnose problems with the wires. It's basically measuring those nerves and how they conduct electricity, so we can tell if a specific nerve is involved or where along that nerve is there a problem. And more rarely used is discograms. When you have degenerated discs, sometimes we can get people to inject the disc to see if that triggers any pain, if that's where we think one of the pain generators is from. But that's not used as often. The main thing is MRIs. So I'm going to talk about the non-surgical treatment options. This is probably what we really came here, you want to hear from us. It's a great thing about lower back pain, a double dose of Aleve and take them with shots of bourbon. Still in pain, I just don't care anymore. That's usually, most people treat their back pain, which is everything except for the bourbon part is okay. So one of the best things for back pain is rest. So obviously we all have a lot of people work strenuous jobs, and so much you can do with that. But you want to try to avoid any strenuous activity. We want to give the time for those muscles and ligaments to rest and recuperate from the inflammation and the strain. Contact sports, obviously, it's very strenuous. Minimize repetitive motions. So even though something like gardening is not stressful, but being maybe bent over and continuing to do the same motion of maybe picking weeds or whatever, or raking or anything, that repetitive motion can also worsen that inflammation. You want to minimize axial loading. What that means is sort of pressure above your head, kind of so that weight is not being transmitted to your spine. And then avoid unusual positions. That's like, painters. We get a lot of painters who have neck pain and back pain because if they're painting the ceiling or something high up, they're like in an extended position for a long time or bent over position for a long time. So basically, we want to rest the spine, just like any other muscle group. Just like if you pull, your hamstring or your calf muscle, it makes sense to rest it, to give it time to heal. Again, weight loss is an important part of the non-surgical treatment. Like I said, as we gain weight, we shift the center of gravity forward, away from our spine. It's like carrying a backpack away from, far away. And that puts a lot of stress on all the muscles, not the bones and the disc, but also on the muscles. So it increases the load on the spine, and it also shifts our center of gravity forward. So weight loss is a very important part. And we see a lot of patients who come in and they say, well, I have this back pain for the last year, but I've also gained 100 pounds. So it makes sense that they have to try to find a way to try to drop some of that weight, and a lot of that back pain will go away on its own. Smoking, cessation, smoking, Dr. Bethel spoke about it. I think this is from Journal of Rheumatological Diseases. It's about a 30% increased risk of debilitating chronic low back pain if you're a smoker. So it's not just acute back pain or short-term back pain, but this is talking about 30% increased risk of chronic debilitating, where you can't go to work anymore or can't do the normal things that you enjoy in life. And chronic meaning it's occurring for years and years, and you may not get over it if you're a smoker. So it's something very important. The way it affects you is because it affects the perception of pain, the little chemicals in your endorphins, things like that are responsible for the sensation of pain, and also damages tissue and decreases oxygen flow. The nicotine takes up space for the oxygen to be delivered to your tissues, so tissues don't heal as well. And if they don't heal, then you're going to have that chronic inflammation. as far as medical treatments, a lot of patients can get some steroids. Their primary cares may, or the emergency room, may prescribe some steroids. What it is a strong anti-inflammatory agent, and it decreases inflammation very quickly. So trying to hopefully control that inflammation in the disc or the joints and the muscle. But you can only really use steroids for a short term. Usually they give it to you for maybe a week or 10 days or something like that. Because there's a lot of side effects from steroids. So even though it's a very powerful anti-inflammatory, the side effects are too great to use it on a long-term basis. So the thing that we often use long-term is things called non-steroidal anti-inflammatory drugs. So that's your over-the-counter stuff like Motrin or Advil, things like that, Aleve, things like, and these are all, it blocks sort of the inflammatory signals to hopefully decrease the inflammation. But they have side effects as well. People can get ulcers, people can get kidney issues, but it's much less than steroids. So, and as we all have experienced, we all take Advil and things, we get pain, things like that here and there. And it works well. But usually when you have an acute bout of back pain, we give you a prescription dose for about 4 weeks or so, and you take it every day to really hit hard at that inflammation that's going on in your joints or your, the muscles or the ligaments in your back. Muscle relaxers, again, because the muscles are in spasm, that's what muscles do when they're angry at us. They give us Charlie horses, and same thing in your back. So all different kinds of muscle relaxants, but that's to break up those spasms, okay? To allow for that muscle to then relax and then rest and heal, instead of being chronically locked up and the muscle will never rest. This is very important, physical therapy. So all those like steroids, the NSAIDs, the muscle relaxants are all to help control the pain so that we can do physical therapy. Okay, physical therapy, it's muscle strengthening, so we want to strengthen all the paraspinous muscles, the abdominal muscles, the gluteal muscles, the hip muscles, everything involved in maintaining stability of our sort of our spinal region. So the stronger the muscles are, the better they'll be able to handle the rigors of our daily life or our job, et cetera. Okay? Stretching as well, the ligaments, so it can be things like traction, and it promotes muscle and joint flexibility. So by stretching everything out, stretching the ligaments, the joints, it promotes that those joints are more mobile and flexible so that, again, so that it can withstand the rigors of the twisting and bending every day. There's passive treatments that they can do, like ice heat or ultrasound or electrical stimulation of the muscles. And that can also help break up muscle spasms and help accelerate the healing from the inflammatory stuff going on causing back pain. They can do posture training. Just so this is a little cartoon of like in the neck is this person's neck is hunched forward, so that center of gravity of his head is in front of his spine. So you want to get better posture to shift that center of gravity back closer to that center of axis that we keep talking about, so that the muscles are at a mechanical advantage. Opioid pain medications, these are also just short term so that you can get over that hump of pain so you can do physical therapy. Lots of different kind of stuff out there. It's great for acute pain. The problem is you can develop tolerance. It can be addictive, and there's overdose potential. And we see in the news all the time patients with back pain or joint pain that get addicted to this stuff, and the DEA now is starting to crack down, and it's a big issue, this opioid addiction. We lost a lot of good people from it. So if all that stuff is not really working, then our colleagues, the pain management doctors, can do injections. Okay, so injections are basically, there's different, this cartoon is just really, you don't have to remember, it's really just to illustrate that there's a lot of different kinds of injections, and it's up to us and the pain management doctors to figure out where this pain generator is from so that we can direct you to getting the right injection. And basically it's a combination usually of some steroid and some anesthetic to help kind of hit that area that's inflamed very hard so that you can decrease the inflammation. And again, can't highlight enough that the right injection is important, because if your pain is coming from a joint and not from the nerve, you getting a nerve block is not going to help. You really need sort of set block. So, but we're here to help guide where to go from it. But this is sort of the next level of if all those medications and physical therapy is not working. And obviously there's alternative treatments that we don't know that much about, but it does work. I mean, yoga we do, it stretches, it's kind of like physical therapy, but there's things like acupuncture, biofeedback, healing hands, Reiki, all these things, cognitive therapy that can also help, especially in people with chronic pain, change the way our body reacts to pain and the chemicals that are released with pain, and it also can help. But the most important thing about all this is that none of those treatments works well by itself. So sometimes we have patients come in and say, well, I took the steroids, but I didn't do physical therapy, or I didn't do anything else, and I still have this pain. The whole point is that all these treatments it's working together to help improve the mechanics or the muscle or decrease the inflammation. I tell patients all the time, it's like just doing one of those things, it's like telling someone to go fishing and catch a fish with maybe with just the fishing string, with no rod or no bait. Or, you need everything together to achieve success. So you need the physical therapy, the NSAIDs, sometimes some steroids or pain meds to get you over, muscle relaxants, weight loss, everything together to have the best success of getting rid of back pain. Finally, I want to talk about red flags. So, back pain affects us all, but there are some things that will sort of in our minds give us more caution that may not just be simple muscle strain, and this is something where then we want to work faster at figuring it out. So if you have severe radiating leg pain or numbness, that's a sign that you have pressure on your nerves potentially, and that something else needs to be done rather than just simple physical therapy. Obviously, leg or foot weakness, you don't want your nerves in your legs to be permanently damaged. Bowel bladder changes can be, if you notice that with the onset of your back pain with losing function of your urine or being able to hold the urine in, that can be a sign that something dangerous is going on. It's pushing against the nerves that run to your bladder. Numbness in the groin region. These are really kind of cauda-equina type syndromes. That's basically where you have a large acute stenosis causing severe pressure. History of cancer or infection. So if you're a lung cancer survivor and doing great from it, but starting to have back pain, all of a sudden, you may want to not blow it off, but it could be a sign that the cancer could have spread to the spine. And the earlier you detect it, the better treatment you can get for it. Rapid and unintentional weight loss or malaise, meaning just feeling yucky in general, fatigue or night sweats, can all be signs of perhaps some sort of infection or something like that going on. And we'll have to be more rapid in trying to diagnose what's going on rather than just trying to go through physical therapy and rest and things like that. So that's basically the non-surgical treatments. And again, thanks for letting me talk. And just remember, back pain is alteration of the mechanics of the spine. And we have to return that as normal as possible. And that's what we're here to help you with. So Dr. Bethel is going to talk about the surgical treatments. So if all this stuff fails, or if one of those red flags turns out to be something real, then we're forced to do surgery, to save function. And Dr. Bethel will talk more about that. But thank you.
So I know that you come to listen to a pair of surgeons talk about treatment for back pain and getting rid of pain, but I'm sure that Dr. Liang and I would you would agree that if I were to take a normal back and go in and cut open their back and deconstruct part of their spine, that they'd wake up and want to probably do the same to me. So what we're going to talk about a little bit after, Dr. Liang eloquently told you about all the conservative methods. And I want to tell you that, being in the category of now 20 years in the business, that's probably 80% of the treatments that we would love to do. And the problem with the United States is, unlike a lot of our European neighbors, we become less active after college. We become more active in basically what my father says is going to work so that we can pay our health insurance. And the unfortunate thing is when we do that, we abuse ourselves. And one of the things, as you've learned, is that takes the biggest hit is our backs. Okay, the stress causes strokes, number one, headaches, and then number two, back pain, because we wear ourselves out. We spend more time at work than we do in exercise. We spend 2 to 6 weeks out of a year vacationing, taking time off for ourselves, versus the 3 months that the average European takes. And I don't know what it's in search of, but it's definitely not in search of healthier backs and healthier spines. So what we do in our job, the majority of what we do where we supplement what goes on here in the hospital is by operating on you, okay? And we would love more than nothing to be out of business in terms of what we do, but that would take a lot of effort on our part at early stages of your lives educating. I used to spend, when I was working at another hospital, I used to spend a good part of my time in the city going to schools, teaching the young women who I was seeing too many of about what kind of backpacks to use. Because I went into there was one high school in particular, Mercy High School in downtown Baltimore, where the girls lost their lockers because they just didn't have enough space. And so the girls were carrying about 60 to 80 pounds on average of books around all day long in a backpack. Now you're talking about 85 to 115 pound young women who are in the developmental stages of their backs and bodies, carrying around 80 extra pounds of weight on their backs. And they were coming to me with what looked like 30 or 40-year-old degenerative discs. I had 4 or 5 of them in 1 year, and I went to find out, it turns out this was the problem. So we instituted a program of roller bags. If they weren't going to give them lockers, the next best thing was, let's get the weight off of their bodies and at least get them something where they could, get the weight away from their bodies. But this is what we do to ourselves in life. And so, as a part of the last resort, after everything that Dr. Liang explained to you fails, we start looking at alternatives surgically. And what we do is not a cure. Okay, it's not like taking out your gallbladder. It's not like taking out a cancer. This is a patch, okay? And I can guarantee you that there's people in here who've already had this patch once, or twice, or maybe 5 or 12 times, as many as I've seen, okay? And they're looking for the next step. And I'm not sure where, and this is part of our job, is to explain to you what we think about surgery and what we do. And we always would love not to do it if we could get rid of your pain. But sometimes there's no other resorts, and you've tried everything else, and you've done everything you can possibly do to get rid of the pain, and then this is where it comes down to the last resort. And Dr. Liang talked about, and this happens all over your spine, the things that there's definitely no way we can get around it, okay? Cancers of the spine, tumors of the spine, infections in the spines, traumatic injuries to the spine, which is not the majority of things we see, but we have to do surgery on because it's in a situation of instability. If we don't do something to help your spine surgically, you won't be able to walk. You won't be able to use your arms, whatever. But there are some situations, like in the degenerative process, if we had talked to you back when you were 9 and 10 years old about how your posture training was, where you were structurally, and it goes back to an article I just read about home economics, how it's not being taught in the schools anymore. We don't know, kids don't know how to take care of themselves on a day-to-day basis. Like 27% of all kids know how to fry an egg or how to boil an egg. So those kinds of things go back to what, taking phys ed out of the school system and learning how to stand up tall, and to stand so that you're actually using your biomechanics, eat correctly so that you're not gaining weight at an early age so that it doesn't become a cascade down the hill for your spine, okay? But when it gets to this point, we have to think of alternatives. And for us, it's all about tissue destruction. How little can we do in order to get you to a point where we're making things look the way they should look without doing too much damage on the way and giving you the most amount of time to get through the next level, okay? Because we can't give you anything that's gonna last forever. Because the average age now, we're looking at life expectancies of 110 years old. So for 110 years, you're going to be standing upright with a degenerating spine, with muscle atrophy, which means your muscles are degenerating as well. So you're going to have less of that strength to hold your spine up. So what are we going to do in order to get you to a point where we're not doing too much damage to get you structurally where you were or close to where you were? Okay? Because what we do causes pain. So some of the things that we've come up with over time are things that try to mimic, and we never get it right because we are not the Almighty, but things that we make that will help mimic or try to mimic what you had before when you were 100%. One of these things is a device that basically acts like a motion segment in between your spine. Now this is still, this device is very controversial, but this is a device that actually works sort of like a structural ligament, a strengthening ligament that moves. And it's an alternative to some of the older methods that we use that we still use as the gold standard today. There are devices now that we put in to give your spine room. Dr. Liang spoke to you a little bit about stenosis, lumbar stenosis, when things collapse and degenerate and basically fall together so that things are being pinched up. One of the devices that we use can go in between those spines and open them up so that we can give you more room by stretching the ligaments out. Oh yeah, we want to go to, I'm sorry. I didn't even notice. I'm so busy looking at the one slide. So this is one of those devices in a situation where the ligaments are buckled. Remember when I told you things are collapsing and the ligaments are buckled? We can put one of these devices in between the spine and spread it out. And it's a minimally invasive procedure that opens up the space. Now remember that when your ligaments are buckling, you're also developing degenerative bones. So there's some times when the joints in the back and the joints in the front are still forming those bone spurs. And even putting one of these devices in isn't going to make enough room. So we still have to open up the space. So this has a very limited application. Even though it's a wonderful little device, there probably aren't a whole lot of people in this room who this would work for because it's just not enough. It's like putting a door stop to let the air out during a house fire. Okay. This has several names, an X-stop device. The other one that was on the market that is not as big is, what was it, the Coflex device. Yeah, so the X-stop and the Coflex are the two big ones, but there are several others on the market. But those devices are, you know, plus minus, and they have some complication of risks and so forth. So the question is, how many of these can you put in and how many levels? We don't do a whole lot of them in our practice because it just doesn't apply to our people. Our people here in this area are hardworking, worn out, and come to us with more than this problem will take care of, than this device will take care of problematically, okay? But some of the things that we do normally, we have developed other structural things, means lightweight devices that will help do what we normally do, but at less invasive cost and at less cost to the community, the medical community, and work better. So, for instance, this device is a little plastic device that fits in between in where the disc used to be. We used to use a piece of hip bone or a piece of cadaver bone from a wrist, or and basically we can now use these plastic devices and fill them up with bone substitute, not even bone that we take from you, and that'll work just as well in most circumstances as if we'd taken a piece of your hip, which actually had more pain than the actual spine surgery itself most of the time. All right, so back in the day when we were harvesting people's hips with a high morbidity, 50 to 70% morbidity and mortality, you know, we don't have to do that anymore with the risk of injury to the grafts, to the bone and everything else. And then nowadays what we've got is in the old days we used to just slap a piece of bone in the disc space and put it in a cast and pray to God that it would heal over 6 months. And then over time we developed instrumentation systems that would help augment, like rebars in your foundation, that would help us get to a higher rate of success. You know, it used to be that lumbar fusions with just onlay bone graft in a cast were 30 to 40% success rate for fusion. Most of them were failing because you can't, it's like, you know, gluing your door closed when people are walking through it. But if you glue the door closed and then slam some plates across the front of the door, more chances that glue is going to set. And that's what we did with developing these plates, and over time those plates got better and we learned more about the biomechanics, and we were able to make plates that actually did things that we knew would help the fusion work, like make the screws slide inside the plate. Okay, and all those things over time have gotten to the point where we realized, hey, maybe we don't necessarily at one level of a disc replacement need a plate. Maybe we can put something in there in the space and then somehow secure it in the space so that it's not sticking out on the front of the bone. So we developed devices like the one up in the left corner and the ones down on the bottom, and then we developed a porous metallic device that actually grows in like bone. So we have plenty of those on the market now. And all these things are less invasive, they're less profile, they can be placed a little bit easier because they're orthogonal. You can put them right in a little space and they go straight in instead of having to go up and down with screws and everything else. So the incisions can actually be smaller. And so those are some of the things we've done with these type of procedures. Now these procedures in particular are all, in the neck, are all kind of based on that whole collapse we told you about with the bone spur formation and the disc herniations that cause the root pain, the nerve root pain that Dr. Liang was talking about in the legs can also happen in the arms, irritation of nerves. What we do is we go in and under a microscope, and sometimes under an endoscope and actually through a tube, we can actually go in and take the discs out, all right, minimally invasive, and then we can shave them out and put a device in there that it replaces them if we need to. Sometimes in the lower back, we don't even need to do that because that disc is herniated out. All we have to do is take that little piece of disc off and let it heal up. That's called a microdiscectomy or an endoscopic discectomy. In this situation, we can take the disc out, take the bone spurs off with a drill, free up the nerve roots, make the space taller again, and put a device in there that mimics the disc, although it doesn't move so well. So what's the next step? Well, say you came to us with one disc problem, it just acutely herniated, there's no bone spur formation, it just happened. You were lifting something out of your garage, and you blew a disc, and now you got this bad arm pain and some neck pain. Well, we can put devices in actually that, these are the old bone grafts, and we can put in these plastic spacers, and we can put in these metals, and sometimes we can actually put in a device that moves, okay? And it's a disc replacement, and that's a newer device that has nothing to do with these plates, okay? These are all settling devices. But we can put in a device that actually replaces the disc completely and moves like a disc. And this is new innovation as well. If the bigger problem is that your nerve root is compressed and you're having a ton of arm pain and weakness, we can actually go in there and replace it. Now, granted, once again, it comes into a situation where a lot of people are far too progressed for this, and they're having a lot of mechanical pain because of all the arthritis they form. So if we put this device in a person with a ton of arthritis, and the studies are different in Europe than they are here, sometimes that can exacerbate the pain because now you have these arthritic joints in the back that are being hypermobilized by a disc that moves, because we can't recreate your disc. This thing moves more than your disc, all right? It actually has a lot of range of motion. So putting this in actually could exacerbate the pain that you're having in your muscles and joints in the back because there's so much arthritis there. So we've got to pick and choose who our patients are, most importantly, who will get this surgery as well. So going back to our other patients, so the gold standard for us in plating nowadays is putting in a plate to hold up like a strut, to hold up those disc spaces to give you freedom for all those nerve roots hanging out there so that they're free from all the bone spurs and all the disc material. And then we fuse those. And people tend to not, we have a 92 to 99% success rate with this procedure in terms of taking care of your neck pain and taking care of your arm pain if it hasn't been going on so long that you've now damaged the nerve, okay? So it's a great procedure, but remember, we're taking wheels off the car. So if we take out a disc or two, then the other discs have to compensate because your brain's still saying, I want to move, right? And now you got two less wheels to move. So if you're doing the same abusive, non-postural activities that you did before, there's about a 30 to 40% chance you're going to wear out another disc, burn out another tire. And now you got a two-wheel car instead of a four-wheel car. So there's probably a higher risk that you're going to damage those, okay? So it's very important that once you do have these types of surgeries, that you continue to do what Dr. Liang was talking about before with physiotherapy, posture training, all of those things. Waking up every day thinking, I got a bad neck, I got to take care of what I got left so that you never end up on the table again. Okay, so going through these devices, this is the one that we all hate to talk about, fear the most, but do the most probably, and that's the lumbar fusion. So lumbar fusions are basically reconstructing the lower spine. And the most obvious way during the 1970s and 80s, the approval for putting screws in to hold together the spine, these are arthrodesis screws, came to fruition, and now this has become kind of the gold standard. basically going in and putting in these rebars, this structural ability to put this together so that it has a much higher healing rate, up to 80% versus the old 40 to 60% that we had by putting bone graft in there and just putting them in a brace for 6 months, putting patients in a brace. So now we've got this great method of healing people, and of course, wherever there's a hammer, everything's a nail. So, when someone comes in with mechanical back pain and they're at a certain age and they've failed a few conservative treatments, first thing everyone in our world wants to do, not us, but a lot of guys will go, there's the saying, if you have a back in the blues, you can get a fusion, right? And that's Blue Cross Blue Shield. So we're trying to, our practice isn't like that. We're always trying to find the alternative methods, but sometimes we have to go to this. But we want to make sure that when we do go to this, that we treat you and we give you all the other modalities to help continuous management of this thing so that you don't have to come back and see us again for more dominoes. In other words, stacking these screws on top of each other, because we see that 30 to 40% of the time as well. This is the newer version of the Harrington rod. The Harrington rods were the old hooks and ladders, and they went up and down the spine, and we used to use Harrington rods, were created for scoliosis patients, and they had the application of using this. These are newer pedicle screws. This is one of a million. This is a multi-billion-dollar biomedical industry. There's probably in the realm of 300 companies that make these screws now, because if you get 1% of this business, it's about $1 billion worth of profit. Okay, so with that in mind, you can imagine, and this is why the federal government is involved, and with surgeons and saying, hey, you can't, because a lot of surgeons design these things, and you can't, it's a lot of anti-kickback and all that stuff, laws that go on, and none of, the ideal situation is you find a surgeon who, is ethically and morally ready to take on your case, that will do the right thing for you. And that's the key, is that if you have the right X-ray and everything, this can be done. All right, it's not that it can't be done, but the question is, are you the candidate for it? Are you optimized? Are your diabetes under control? Are you not smoking? Because smokers fail about 50% of the time. Is your weight controlled to a degree that you're not going to pull this out of alignment once we put it in? Is your bone integrity good enough? Do you not have osteoporosis because of course putting metal in spongy, styrofoam bone is going to break out? Seen it happen. Are you at high risk for infection? Because if these get infected, they stay infected. They don't have a blood supply, so there's no way to get antibiotics to metal. So they have to come out, and that's a risk factor. And then, of course, you're going to do all the things we need to do to maintain this so that the next disc doesn't go. So basically, we can go through the gambit, and the nice thing about Dr. Liang and myself and Dr. Solomon and the rest of our orthopedic spine group is that, we like to talk to you on an individual basis, because everyone's different. Everyone's got a different story. Even though we all have spines and they all suffer from the same problems, we all also recognize the different details. This is an art. Spine surgery is an art. And that's why we do it, because we like the challenge of dealing with the individuals and trying to find out the right thing for them. Okay? And a lot of times, Dr. Liang and I'll tell you that we see patients who've already had surgery. And they come to us with the same complaints. And it may have been that the expectations were different than what was told to them, okay? And that happens very often, So we try to be upfront and honest about what we think about things. I've been told that, I'm very blunt about the way I am. It's part of me because I'm from Jersey. And, the other part is, because I like to tell people what I would want to hear from my doctor. The honest truth, And it's not something abnormal, we all have these problems. Back problems are that common. But there's always a treatment modality. And sometimes it is surgery. I would say 20% of the time, surgery is the way to go immediately, okay? But then the other 80% of the time, down the road, surgery might be the thing, but there may be a plethora of other things that we could do to treat your pain. And that's the nice thing about our practice, is that we have the options to give you all of those options and to talk to you individually about what you have going on. So I hope you got enough information from Dr. Liang and I, and we're more than happy to answer any questions for you at this time.